Good evening and welcome to the Truth Exposed, the Effects of COVID-19 and Being Black in America, a virtual panel hosted by the Center for Equity, Justice, and the Human Spirit at Xavier in partnership with the Center for Minority Health and Health Disparities Research and Education in the College of Pharmacy at Xavier University of Louisiana. My name is David Robinson Morris, and I'm the founding director of the Center for Equity, Justice, and the Human Spirit, and your moderator for tonight's very important panel discussion. As I like to say, first let me pay the bills and tell you a bit about the center. The Center for Equity, Justice, and the Human Spirit is a response to our calling as a Black and Catholic institution of higher learning, and just one way that we can put into practice the knowledge that we pursue toward the creation of a more just and humane society. It is the present point of intersection that brings together 95 years of our history of combating and traversing oppressive systems, triumphing in the face of adversity, reclaiming our shared humanity, and educating human beings who go out into the world ready to do justice always and in all ways. Just over 2 years old, we've centered our work on 3 areas of great importance to marginalized communities over the globe: educational equity, criminal justice reform, and environmental justice and sustainability. Please also allow me to thank Tanisha Fields with the Center for Minority Health and Health Disparities Research and Education, and Karen Blair, the center's program coordinator, for their work in assisting in setting up the panel. Like many of you joining us tonight and those on the panel, I'm angry, I'm inquisitive, and I want real, sustained change. The current national dialogue on Black death and COVID-19, quite frankly, pisses me off. As I've written elsewhere, it reminds me that the sin of racism is death, or as Ruth Wilson Gilmore writes, racism is the production and exploitation of group differentiated vulnerability to premature death. I recently read a Brookings Institute article by Rashawn Ray. Ray begins his article by remarking, "There's a saying, when Black America catches a cold, Black people get the flu. Well, in 2020, when America catches coronavirus, Black people die." The statistics knocked the wind out of me. For example, in Illinois, Blacks represent 16% of the state, with 30% of the population diagnosed with COVID-19. In Chicago, 30% of the population is Black, yet accounts for 52% of COVID-19 infections and 72% of the deaths. Or in Michigan, where Blacks comprise 14% of the population, yet accounts for 35% of the infections and 45% of the COVID-19 deaths in that state. And right here in Louisiana, 33% of the population is Black, yet this population accounts for 70% of the COVID-related deaths. We cannot discuss these alarming statistics without contextualizing the immenseness of Black suffering in this country's long history of structural anti-Blackness. We cannot discuss these statistics without discussing the structural inequities that cause racial health disparities, like inadequate housing, like the racial composition of neighborhoods where Black neighborhoods relative to white neighborhoods are more likely to lack healthy food choices, green space, safety, and recreational areas. We have to discuss public transit, lack of access to equitable health care, and we damn sure have to discuss how Blacks are more likely to be members of the essential workforce, nationally representing 30% of all bus drivers and 20% of all food service workers, janitors, cashiers, and stockers. The questions for us tonight to consider is this: why are Blacks dying at higher rates from COVID-19? And what can we do about it? Tonight's panel will begin with introductions of each panelist, followed by brief introductory remarks by each, and then we'll jump right into the questions. The first set of questions are designed to address tonight's topic, followed by a Q&A comprised of questions previously sent in by some of tonight's virtual attendees. If you would like to ask a question, please use the Q&A, and I'll do my best to ask your question or an iteration of your question during the Q&A period. Now, please allow me to introduce our panelists. Representative Royce Duplessis is a 2004 graduate of Xavier University of Louisiana. Royce was elected to serve the people of Louisiana House District 93 in 2018, where he serves on the Ways and Means, Criminal Justice, Labor and Industrial Relations, and House Executive Committees. District 93 includes the New Orleans Business District, Warehouse District, French Quarter, Lower Garden District, Central City, Lower Mid-City, Treme, the 7th Ward, and St. Roch neighborhoods. Royce has dedicated his career to public service. He owns and operates his own small business, Duplessis Law Firm, LLC, focusing on civil litigation. Dr. Esteban Gershnik is a leader in medicine, management, and health information technology with experience in small and large health systems, academia, startups, and the public sector. He consults on projects across the country while working as a hospitalist at Brigham and Women's Hospital and Dana-Farber Medical Institute in Boston, and as a pediatric hospitalist at Children's Hospital of New Orleans. He previously served as CIO, Health Informatics Director, and Medical Consultant for the Louisiana Department of Health. He applies the principle of mission, collaboration, data, and innovation to drive strategies for success. In the last 6 weeks, he has led efforts opening and running the first federal drive-through COVID-19 testing, and then with the National Guard and the Health Department in New Orleans, along with establishing and operating the medical monitoring station at the Morial Convention Center. Dr. Tori Harris, a 1998 graduate of Xavier University of Louisiana, is a New Orleans native and a public health practitioner with 20 years of experience with a focus on health disparities, community health, and public health systems and services. As the health and equity strategist for the New Orleans Health Department, Dr. Harris incorporates a racial equity framework into the structure and function of the department through leadership development, organizational capacity building, staff training, and community involvement. Dr. Harris is also responsible for Trauma-Informed Schools Project and working with Making Connections, a Black men and boys mental health project funded by the Prevention Institute. Dr. Harris's primary goal is to undo racism within public health and the healthcare systems to assure equitable health outcomes. Dr. Kathleen Kennedy is the Dean of the College of Pharmacy at Xavier University of Louisiana and an endowed professor of health disparities research and education. In 2004, she was appointed director of the Center for Minority Health and Health Disparities Research and Education, where she served until January of 2009. As the director of the center, she provided leadership in the development of the research infrastructure necessary to support health disparities research, education, and training in the college. In 2007, Dr. Kennedy organized the first National Health Disparities Conference for mid-level healthcare professionals to address the successful translation of research into effective models of practice to impact policy and change behaviors in the broader community. The conference continues annually. Dr. Kennedy currently serves on Governor John Bell Edwards' Louisiana COVID-19 Health Equity Task Force. Andronika Morris serves as the Executive Director for Housing NOLA, a 10-year public-private partnership working to end New Orleans' affordable housing crisis. The 10-year strategy, released in 2015, indicates the need for 33,600 new affordable housing opportunities by 2025. In 2016, Biz New Orleans magazine named Morris one of the top 10 influencers in real estate. Gambit Weekly named Morris New Orleanian of the Year for her role in Housing NOLA's historic efforts in 2017. In celebration of New Orleans' historic tricentennial celebration in 2018, JP Morgan Chase partnered with NOLA.com to name Morris one of 12 icons of New Orleans as part of its 300 for 300 campaign. Dr. Daniel Sarpong is a trained biostatistician, is the director of the Center for Minority Health and Health Disparities Research and Education, endowed chair of health disparities and professor of biostatistics at Xavier University of Louisiana. He is also the director of Xavier RCMI, Cancer Center Community Engagement Corps, and director for Community Engagement and Outreach Resource of the Louisiana Clinical and Translational Science Center. Dr. Sarpong currently serves on Governor John Bel Edwards' Louisiana COVID-19 Health Equity Task Force, Health Disparities and Research Subcommittee. I welcome you tonight, panelists. And I open the floor to each of you to give your opening remarks. And we begin with Dr. Kennedy.
Thank you very much, Dr. Robinson Morris, for that introduction. And I'm happy to be a part of the discussion tonight to talk about this important topic, health disparities and moving toward health equity. As you mentioned in your remarks, the main goal of the Center for Minority Health and Health Disparities Research and Education for me was to support research by our faculty to come up with strategies to impact the disparities and move toward health equity. And I recognized that it was important to translate that research into clinical practice. And that's why the conference began to let individuals know that mid-level providers as part of the healthcare team can play an important role in working toward health equity. And it gives us an opportunity to bring policymakers together as well as health professionals to talk about strategies and to take those strategies back into their communities to really make an impact on trying to help individuals, empower the people in the community to look at their own health. My area of interest particularly is in cultural competence and health literacy. And I think it's so important that our health professionals are trained to look at the cultural sensitivity of the individuals that they're treating and to make sure that we're speaking their language when we talk about health literacy. It's one thing to talk to our patients in the community, but if they don't really understand the importance, and when we look at COVID-19, we know that we're not getting the clear message across to people that we need to. So I think that those are really very important topics that hopefully we'll talk a little bit more about tonight. I'm also the chair of the Greater New Orleans chapter of the American Heart Association. And as you know, many of the diseases that disproportionately affect this community are heart disease. And of course, one of our goals is to decrease the deaths that occur because of cardiovascular disease. So I look forward to discussion about that. And finally, just to say a little bit about the research that's going on in the college related to COVID-19. We have a group of faculty who are working on whether African Americans are going to be receptive to a vaccine once it's developed. And I think that's important that we talk about that. And another group, we're talking about the antibody testing. You may have seen that in New York, they looked at data which showed about 21% of the individuals were positive. And antibody testing is going to be important, is one of those important measures that the state will look at when they're talking about opening back up. So we're wondering what that would look like in Louisiana. And so there's some discussion about getting involved in looking at antibody testing. Of course, we have to realize that some of the tests that are out there are not as accurate as they should be. So all of that will be taken into consideration. So again, thank you for the opportunity to participate in the panel.
Thank you, Dr. Kennedy. Representative Duplessis.
Thank you, Doctor. I appreciate this opportunity to be a part of this conversation. After you asked me to be a part, I didn't know that I was going to be sharing the panel with these experts and these very smart, talented, and distinguished individuals. So I guess you had to get the obligatory politician on there just to kind of, just have somebody on there other than these real experts. But Doc, I just want to start off just by saying how proud I am of you and all that you're doing. You and I go back many years, and I'm just a fan of the work that you continue to do and the way that you're using your voice and advocating for the most vulnerable in our community, and to be doing it at my alma mater, Xavier University. I'm truly proud and inspired by the work that you're doing and the center that you founded. I want to start just by going to some of your initial comments at the beginning, starting with the fact that you are pissed off and acknowledging the fact that I share that sentiment. And I'll go to a quote, one that you probably know pretty well, that most of the people on this panel probably know pretty well, and that goes back to the late great James Baldwin, who once said, "To be a Negro in America and to be somewhat conscious means to always be in a rage." And when we have these kind of conversations, it evokes that emotion. I think the purpose of this discussion is to take that deep dive, the dive that many folks don't want to take, understandably so. But we can't get to the root of this without being willing to have these very difficult and often heavy conversations. And I want to start with the fact that personally, I'm not in this just to have a conversation, and I don't think any of us are. We want to be able to leave this panel with some clear understanding about how we got here, or more clear understanding of how we got here, and a better understanding of how we can move forward. And certainly recognizing the fact that we did not get here overnight, and these problems will not be solved overnight. Going a bit further, just to the title of this program, that the truth that it exposed. I don't believe it exposed anything. I believe that it just highlighted what was already there. We saw the same thing after Hurricane Katrina. It just put a bright light on what already existed. So we have just been living in these conditions, but not being willing to take the deep dive and address the implicit and oftentimes explicit racial bias that exists in society, that has always existed in America. You pointed out the district that I represent. One part of my district, Lower Garden District, the life expectancy is around the age of 85. You go to the other part of my district where I live, Central City, and it's 65. Those statistics just didn't come about as a result of COVID-19. That has been the case. So this pandemic that we are experiencing, I think just further highlights the disparity. I chose to go into public service for multiple reasons, but primarily because of the fact that I was disturbed by the inequity that surrounds the community that I love. And I think one of my biggest responsibilities as an elected leader, as a policy maker, I don't necessarily see myself as an advocate per se, but I can use my voice to advocate. But all of those roles that I played as a state representative, I think one of the main responsibilities that I have is to recognize cross-sectionality of policy and intersectionality of policy, and that we can't govern or think that we can begin to solve these problems by approaching them in silos. That means that if I'm talking to Ms. Morris about housing policy, I have to understand the impact that will have in conversations with Dr. Kennedy around health education, because we know that wage policy, economic policy, housing policy, all has a direct impact on our public health. So that makes the job much more difficult and challenging, but it's all connected. And I'll make one last point and turn it over, because I know we want to get other people's perspectives. we talked about the fact that the governor created a task force right after this these statistics were revealed. And I'm certainly glad that people like Dr. Kennedy are serving on it. And I'm looking forward to trying to be as supportive as I can to this task force. But the truth of the matter is, I don't know what this task force is going to tell us that we already didn't know. So the real question is, what are we going to take from this task force and what are we going to do with it, right? How committed to this are we as a state and as a country? And again, I think I'll just wrap up with this. You look at the fact that the Health Equity Task Force was created, and just a few days later, we had a resilience committee that was created to focus on economic policy. Well, when I saw that, I'm saying, well, why do we have a separate resilience committee? Because if we're talking economic recovery, how can you separate the two? If we're serious about equity, it has to be at the center of every conversation. And when we compartmentalize the issue of equity and racial justice, then we're doing just that. We're leaving there we're saying, okay, we will get to that when we want to get to it, as opposed to taking up the challenge and issue of saying it unfortunately has to be at the center of all policy decisions. And you cannot compartmentalize this issue because it's embedded in all corners of society and all corners of thinking, whether we want to admit it or not. So I'll leave it at that and turn it over. And thank you for allowing me to be a part of this panel.
Thank you, Representative Duplessis. Thank you for being a part of the panel, and thank you for your work. We're going to ask Dr. Harris to follow that.
I was on mute. Thank you, Dr. Robinson Morris. Actually, Royce kind of stole some of my comments, or he lifted up some of my comments, but in my role as the public health or the health and equity strategist at the health department, I've been working on the front lines, managing and serving as incident command at the COVID-19 testing centers or testing sites. And part of my job is to work with our staff internally and our leaders at the government level to make sure that everything that we do is using a racial equity framework. And through my lived experiences living in New Orleans and seeing what my family has experienced with our healthcare system, that has brought me to public health and to think about health as broader than just your individual level health. And we have to start thinking about what are some of the root causes of these inequities that have persisted for New Orleans over 300 years of our founding, and also what is causing the mistreatment? What are the biases and assumptions that we have about people that are leading to these inequities? And so the expertise that I bring to the table within our health department and within our communities is leading conversations about race and making sure that it's always on the table, even when we're talking about our health. And so, like I said, Royce made a lot of my statements, but I do want to have everyone give thought to two questions. I've been listening to a lot of these seminars about the inequities and listening to some of the statistics about inequities, and it's quite traumatizing to hear, that my health is a disparity. And getting phone calls from family members that are in the hospital or dying. So, I was on a phone call yesterday talking about this topic, and one of the speakers said the federal government has spent $2 million in stimulus for COVID. And so that tells us that the US government can finance anything at any time if they want to, if there's political will. So we as a community have to lift up our voices and state what we want. We need to rethink and reimagine our government and organize our communities to develop these solutions together with our politicians and decision makers and leaders. And the two questions I want to leave you with, the panel and everyone on the call, is What would it look like to live outside of the frame of white supremacy and patriarchy? What would it look like if our financial infrastructure loved Black and brown people and we were respected and honored for our contributions and they were seen as valuable?
Ooh, thank you.
Dr. Harris, I got lucky that I got to go before you. I pretty much stole all your comments because I've listened to you. So I attribute all my comments to Dr. Harris.
Next, we'll have Dr. Gershanen.
Thank you so much. And for me, first and foremost, it's a privilege and an honor to be with such great panelists, and I appreciate the opportunity to be part of this. I was also very humbled and honored to work with Dr. Harris earlier with some of the drive-through testing, and I commend the New Orleans Health Department for not just reaching out to New Orleans as a whole, but also to all the direct communities that we know is the dynamics of New Orleans. Being a local New Orleanian, we know we have our African-American population, but we also have a large Latino and Vietnamese population. And again, as was mentioned earlier, we have to sort of target that community involvement and message things in a way to ensure that everyone is engaged and involved and has the understanding of how COVID-19 can affect us. Furthermore, I think everyone has said everything on point. I think the perspective I'll try to provide on this, having also done some of this work during Katrina, was the fact that often what these stressors do or these crises do is it takes off those Band-Aids that have historically been placed on long-standing institutional issues. So we have to sort of redo the foundation and the infrastructure and stop putting Band-Aids on sort of hallmark institutional issues in order to properly address it. And my hope with this discussion and my background is as a physician, as a public health individual, as someone who has the knowledge and data, and more importantly around here being both a New Orleanian and a human trying to affect our community to improve what's going on. And as we've discussed, the healthcare of individuals isn't just their individual health, but the public health domain, the social determinants of health, and all the other dynamics that they live in. So when I tell a family to physically distance from one another, it's different for someone who owns a big house versus a family of 10 that are in a small apartment. When I have people who are trying to now do virtual schooling at home and only have one computer for a family of 10, that's more complicated than a family of 10 that has 10 computers or 10 cell phones. So this is a much bigger topic than just the health information. And the other component I'll add to that is when I worked with the Department of Health, you start seeing the silos of information. As Representative Duplessis mentioned, there's a bunch of different information in different locations, and there's a lot of committees. I think we have to approach this holistically and have everyone come together, both for solutions in order to solve the information that we need at our hand to make the decisions that aren't just delivery of healthcare decisions, public health decisions, policy decisions, food insecurity decisions, housing decisions. At the end of the day, what these epidemics or pandemics or crises land are stressors. And with COVID-19, what stress does, as a physician I can tell you, is it decreases your immune system, which makes you more prone to death. So the greater stressor you have on you, no matter what it is, the higher incidence and prevalence you have of dying. And the other component of this that we're going to have to look at is when there's a stressor at the beginning of a pandemic or epidemic, similar to Katrina, you then have the psychological component that's going to occur with higher unemployment rates, higher difficulty paying for housing. So the mental health component is something we have to also address on top of it. So again, more I could go into, but for right now, I know we're trying to get the introduction started. So for me, it's a privilege and an honor to take part. I also want to say there's also crisis standards of care around an equitable response that was developed after Katrina that should be key to implementation at this time to ensure we approach the solutions in an equitable fashion.
Thank you, good doctor. Ms. Morris, would you like to go next?
Sure, I had to take myself off mute. Good evening, everyone. Thank you. I join everybody thanking David and Karen for setting this up and inviting me to be a part of it. I appreciate this timely conversation, and I particularly appreciate the recognition that housing is a part of the cure that we need right now. That doesn't happen often, that it gets overlooked, and that's part of the reason we have gotten to this really disgraceful moment in our history, when right now when staying safe at home is one of the best things we can do for our families and our communities, and too many of our neighbors and friends and family members can't do that. A safe and stable place to call home is well out of their reach. In face of the economic crisis that's looming, people are going to lose their homes. That is what's going to happen if we don't intervene. This was a problem before this pandemic, and it's been our failure to address this particular problem that has worsened this pandemic. People went to work sick. People got sick at work because they were afraid that they were going to lose their housing. They were afraid that they weren't going to be able to take care of their family members and their children. And we have to live with that. We have to live with the consequences of those decisions. The 6 months before COVID-19 made its way to our shores, the city of New Orleans had over 350 families lose housing who were using vouchers to rent. They were evicted for a number of systemic problems, challenges and this has been a problem that's been going on for the last 2 years. Now those problems are compounding at a ridiculous rate. Unemployment is soaring, and industries like tourism that are the backbone of our economy will not rebound when these stay-at-home orders end. They just won't. People will not be going back to work the same way. So again, you have people who were struggling on March 1st, who are going to be struggling on June 1st, and have been loaded down with 2 to 3 months worth of debt for utilities, mortgage payments, and there still is no real solution. And so the pandemic has shown us that nobody stands alone, that we have to do it together, and we need our leaders to ensure that they put housing first. Estimates tell us that there are over 14,000 vacant homes and apartments in New Orleans alone that are unoccupied. 14,000, as we have people sleeping on the streets, and we have people being evicted, as we have people doubled up inside of a health crisis like this. We have thousands of vacant hotel rooms that will not be used for the foreseeable future. Yet again, we let people sleep on the street. We let people be doubled up. We let people sit in jail still. There are folks who could be released, but under the JRI, the Justice Reinvestment Initiative, who cannot be released because they do not have housing. This was a pre-COVID problem that we have not addressed adequately. So just like testing and PPE, leadership is a vital resource that we need to get through this crisis. And just like those other resources, leadership has been way too slow to show up. The choices our leaders are making help decide whether and how we are going to weather this pandemic, and how we're going to get ready for the next wave. What do you think is going to happen for people who go back to work the next wave that this happens, and they see that we are not going to respond, we're not going to help them, we're going to let them get saddled with 3 months of utility bills, 3 months worth of rent, 3 months worth of mortgage, 3 months worth of insurance payments. And we're going to say to them, well, you guys got to dig yourself out of the hole and hope that you figure it out. And we've seen no comprehensive program from any level of government that will address these issues. It's an embarrassment, and it's all too predictable. We look at our behavior pre-COVID. This is exactly how we let our leaders behave around housing before this issue hit. And that's why I'm so appreciative to be here tonight to align this issue and make sure people understand how important it really is.
Thank you, Ms. Morris. You just mentioned, so connecting you and Dr. Gershanik, you just mentioned a number of stressors, right, that assist in lowering the immune system and causing other issues, as well as the mental health issues that accompany homelessness and worrying about food insecurity and all of those other things. Thank you for raising that. Dr. Sarpong, last but not least.
Yeah, thank you for the opportunity. I hope that my presence on this panel shed lights on some of the issues that I think is very important. First, I'm appreciative and I welcome the opportunity to serve on the Governor's Task Force on the Subcommittee of Research and Health Disparities. One of the things I'm hoping that this panel event allows us to do is to get the voices from the field. So we want to hear the concerns of the people, because sometimes we have the ivory tower effect. We sit there and we think we know what the problems are, and we try to solve it from that myopic viewpoint. So I'm hoping that the community would get engaged, that will be empowered, and that we would be able to get the information so that we do have the right information, that our decisions as we go forward, not using a bandage approach, but a more consistent and solid approach, would requires having information. So that becomes important, and that our decision making and our strategies are going to be dependent on data, not on emotions, but on data. I mean, I know we're all upset about certain things, but I think part of what we're faced now is that we as a nation have used an insane approach to addressing our issues in terms of health disparities. And why do I say that? Einstein eloquently put it that if you keep doing the same thing over and over again, expect different results, that's insanity. And we keep doing the same thing over and over again, expecting that we're going to get different results every time. So I think we need to go back to the basics. I think it is hard time that we looked at the data and we become very realistic. I think some of my colleagues pointed out that we work in silos and we think that we can separate economics from health. But the wealth of every nation is the people, and if the people are not healthy, you cannot become economically viable. So, and as Ms. Morris said, if these people are not going to go back post-COVID, well, then their economy is going to tank, because we're going to provide those services. So we have to take care of the people, and then the economy will survive. If we're focused on the economy and not the people, the folks ain't going to be there to sustain the economy. So I think we need to move from this whole situation thinking that we could continue to survive in 2020 with structures that are deeply rooted in racism. A lot of the stress is due to racism. It's due to racism. I mean, and even though I call it's somewhat institutional, because it's at the very core of the society. But as a nation, if we're going to continue to be a superpower, as states who are going to be viable states, we need to come together and begin to look at the problem from a more realistic standpoint. Sometimes put politics aside. We're so polarized in this country, it's not even funny. But the message I want to get across to people is that first, let's take care of self. You take care of self by doing the kinds of things that we all basically know, that government has responsibility, society has responsibility. I'm an advocate for personal and social responsibility. It's not just one or the other. Both have to come together for us to solve our problems in society. Sometimes one policy can make a whole lot of difference, because with certain policies in place, I could do all I can, but I'm not going to get too far. I can't get too far. So I think it's very important. But first, let's do the basic things we can do on our own, that it's within our reach to try and prevent the spread. Secondly, I think we all need to boost our immune system, because if you're not, do certain things, maybe try your best, at least have one decent meal or something. And then we all together have to come back, not to go to sleep when COVID ends, or be able to put a lid on COVID, but to continue to be empowered and use the same energy that we're using to find answers post-COVID, because we're just beginning. It said we may win the war, but the battle, but the war has just begun. So I think the wall of being able to deal with racism, addressing health disparities, it's going to be after we put the lid on COVID-19.
Wonderful. Thank you, Dr. Sapong. Thank all of you for those opening remarks. The first question of the panel, and you've all touched on this, right? So I believe very deeply in Sankofa, the understanding of we have to look back in order to move forward. So how the hell did we get here? What are the structural issues that are in place that brought us here today to this point? Not all of you at once, by the way.
I'll chime in because our housing is the issue that has been the one that's long been least addressed. There have been attempts to deal with healthcare. There have been attempts to deal with education. There have been attempts to deal with wage and income inequalities. We believe that those things have all failed because we have not addressed housing, right? You can give somebody the greatest job in the world, and if they got to take a 2-hour bus ride to get there and back, they're not going to keep it. You can put a kid in the best school in the country, and they go home every night, and mama and daddy are fighting about where they're going to live, or they're sleeping in a car, they're not going to do well. So we think that that's been a key issue, and again, it's an incredibly racialized problem. When you hear affordable housing in this country, you think of a poor black woman with too many children. That is the legacy of the Reagan era, that the welfare queen stereotype that has been seared into the consciousness of this country. And that's white or black. When you don't know trauma, or not trauma, you don't know drama, and so you sit in the lower ninth ward and hear community members tell you that they don't mind Section 8 residents, but they don't think they care about community the same as the way that they do. And that these are African Americans who are saying these kind of things about other African Americans who actually don't have a whole lot of difference between them socioeconomically. So this is a huge issue, right? We have got to deal with this message of systemic racism and accept that everybody has to have somewhere safe, decent, and sustainable to live. And again, this crisis has made that abundantly clear. And again, our failure, it has been incredibly disappointing, again, to watch our leadership fail to address these issues. It's going to be 6 weeks from the official stay-at-home orders, and we have still not seen a substantial response. We have got systems that are broken that can be addressed, that can be fixed. This is a will problem, right? There are pots of money all over the place inside the various housing systems that need to be activated, and they have not been. And we've got funding from the state that they need Congress to let them activate. Where's our congressional delegation? There's funding at the convention center. Where's the leadership there to make sure that the tourism workers actually get assistance? The housing authority has resources that they have not been able to activate. Again, where is the outcry? Where's the pressure to fix these things? Commitments are made and commitments are broken inside of the housing work. The city of New Orleans pulled all of the city and state agencies together almost 5 years ago and made a commitment to create 7,500 units by the end of this year. They've actually lost, over the last 2 years, they've actually lost more units than they've created. And this is not information that is unavailable. This is not information that people don't know. It's information that our leaders are failing to act on.
Wow, thank you. Dr. Kennedy, I know you wanted to chime in.
Yeah, I think everyone really has mentioned it. I think that it's racism. Racism has played a part in the health inequities that we see in this country. And I think that was recognized in Healthy People 2010, and even in Healthy People 2020, they actually list discrimination and social segregation as social determinants that impact health inequities. So all the things that everyone's talked about, the housing, the wealth gap, education, there's so many aspects of it, and it's by policies that have caused these things to be inequitable, and they continue, and until we can change policies, we're going to still be in the same situation. So that's something that's very important, and it's good to have one of our representatives here who might help us change some of those policies.
Yeah. See, I'm gonna go back to thanking Dr. David again for having, because you always got to have the politician on there, always, because no matter. Y'all are the real smart folks. I'm gonna just be honest with you. Y'all come up to Baton Rouge, and I mean, we have so much work to do. I want to just follow up on both of those comments and just chime on that comment briefly. I agree with Ms. Morris that this is an issue of housing. I'm going to just go a little bit broader and go a little bit further. I think it's more of an issue of geography, right? and going back to that human connection. How did we get here? Going to your question, Dr. Robinson Morris, how did we get here? We got here through laws and systems that were put in place that were clearly designed to promote the interests of one race and hold back the interests of another race. That's how it started, okay? And over time, through lots of deaths and fights and lawsuits and just resilience, we have made some progress. We've seen big changes, like in the 1950s, obviously, with the Civil Rights Movement and Voting Rights Act and Civil Rights Act and all of those types of things that we saw changes happen during those times. But I think we remain in the place that we're in over those many centuries of race-based policies that have institutionalized racism. And you often hear that term used, institutional racism. But if you try to have the conversation with someone, they'll say, well, I'm not a racist. What are you talking about? Like, there's no racists among us, right? Because we're in a post-race world. We were elected a black president. How could there be any racists in America, right? I mean, this is the mindset of a lot of people. But because we continue to try to adopt race-neutral policies for race-based problems. And that, I think, is at the center of a lot of the reason why we remain in the condition that we're in. Because, again, no one wants to own up to their own racism. No one wants to say, hey, yeah, today is Wednesday and I feel like being racist, right? And listen, the implicit racism, that exists amongst our own, okay? So let's keep it all the way real, all right? This is not just a situation where we're saying, okay, there's no self-responsibility here. This, when you talk about institutional racism, this is amongst everyone. We're all participants in this, okay? And we have to be cognizant of that and work towards trying to rectify it and address it. So how we got here, again, this was all about economic motivation and the idea that in order to achieve that, it was through cheap labor. And yet, and still, in 2020, those who are considered essential, right, to keep the economy going, largely make up a certain race. The people driving the buses, the people picking up the trash, the people who are cleaning up hotels, the people who are on the front line. And God bless and thank all of our healthcare providers, but I'm talking about the people at the lower end of the economic spectrum, largely are made up of the African American and Hispanic community. So, we have to be honest about that. So again, I think your Sankofa quote was right on time, that we have to look back in order to look forward, because we cannot address this problem. We cannot address any of these problems without taking a historical view of how we got here. And it's all really been driven largely by economics. And going back to Adranika's point, and I'll close with this on geography. Sadly, we are now existing in a climate where we can have calls like this on Zoom, but we're more detached than I think we ever have been. We have communities of people who don't engage with one another. Neighbors don't know one another. And by the way, I actually went to a funeral today, sadly, for my neighbor, an older African-American gentleman who passed from COVID-19. And it was probably one of the saddest things that I've ever experienced. But I'm saying that to say, as communities, we're more disconnected, functioning in a world of 24/7 cable news, Twitter, Facebook, and that is what's feeding the conversation, and that's what's feeding our understanding or lack of understanding of people who we don't know or who we don't engage with. So there is a tremendous lack of empathy that exists, I think, in society today, just due to just a lack of understanding one another. And it's really hard to achieve equity with a lack of empathy, because we can just go to our favorite channel, our favorite, whoever we like to hear from, talk radio, and they'll just tell us what we want to hear, as opposed to seeking real understanding, getting to know our neighbors. I just think that's the climate that we're in 2020 that makes it much more challenging.
I was going to chime in there and kind of lend to some of what Royce is speaking of. From my perspective, I think that there's just been a lack of value and care for Black and brown bodies throughout the history of our country. If I took a class on the Constitution recently, and Black people or African Americans weren't mentioned till the 13th Amendment, and when we were mentioned, we were spoken of as slaves or 3/5%. So we were not considered human. And when we look at scientific studies, in the early 1800s and 1900s, they took advantage of Black people by using them for research. Women's bodies were used as research for obstetrics and gynecology. And so we continue to have these times or moments in time where, Black people, Latino people are not treated with any sort of value. And so here we are today. And people are not willing to have these discussions. And so really, until we have these discussions, every time there's a disaster, we're going to be right back here at this moment. And in New Orleans specifically, we've had several epidemics or outbreaks from disease over its 300-year existence. And each time, people of color have been mistreated or thought less of. And so it's going to be up to us to lift up our own voices and advocate for our communities to people like Royce Plessis and say, we need you to speak on our behalf. We need to organize, and we need you to advocate for changing some of these policies that were race related anyway. How can we rethink these policies, because it wasn't set up for us in the first place?
Thank you. We talk a lot about systems, but there's also been a lot of discussion around who's at fault, right? Around how do you protect yourselves, around health literacy. And I'm thinking of the Surgeon General's comments, where he prescribes social distancing and hand washing, and he goes on to say, avoid alcohol, tobacco, and drugs, and call your friends and family, check in on your mother, she wants to hear from you. And speaking of mothers, these are quotes, we need you to do this, if not for yourself and for your abuela, do it for your granddaddy, do it for your big mama, do it for your pop. We need you to understand, especially in communities of color, we need you to step up and stop the spread so we can protect those who are most vulnerable. There is a lot of chatter around this question of fault. And I don't know if it's a valid question or not. That's why I raise it. Do we have a health literacy issue? I know we have a systems issue, but do we also have a health literacy issue? And can anyone be blamed for contracting a virus?
No, I don't think that anybody should be blamed because I think from the onset there was a lot of noise, and really communication of the virus from the very top sent mixed messages. And I think that's part of the problem. In situations like that, when you have mixed messages with different levels of literacy, you create more problem than come out with a more direct messaging. And I think that's what part of the issue is, because we played it around. And also, I think the other issue I want to talk about in terms of maybe getting to the Surgeon General's comment, sometimes we all have to be mindful that we don't stigmatize the victim. We tend to put labels on things, and then it doesn't let us address the issues as we need to address them. So I think we have to be very careful. But I mean, I think what the Surgeon General said may be a little distasteful, and maybe his packaging of the information might not be appropriate, given circumstances and the like. But I would rather go further, because we're in a state of crisis, to look at the content of what he's saying. If he was having this conversation with each and every one of us in our living room, sitting across, and used the same language and framed it that way, I think it would come across very different. I think given his position, where he was, and having that national platform and putting it that way may come across a little distasteful. But I don't think people should focus so much on the packaging. I think at this point of crisis, we need to focus on the content. We may chastise him later on for how he packaged the information, but let's not lose out on the worth of what it is by focusing on the packaging and not the content.
Thank you, Dr. Sarpong. Any other thoughts on that?
I wanted to, Dr. Kennedy, if you wanted to go. Oh, no, she looked like she was
Dr.
speaking.
Kennedy. You're on mute.
I'm sorry, I was trying to, trying to unmute myself. I think that people were upset because, you know, they thought that he was, as Dr. Sarpong said, blaming the victim. And I think that it is important that individuals take some responsibility. But I think there's too much of what's happening, or the way that the data is being presented is like it's our fault. You know, we're dying because we're not doing what we need to do, and we have all these diseases. And you know, again, I think that it is responsible to take, it is necessary to take some responsibility, but it's not all our responsibility. There are reasons why there are inequities and reasons why people have chronic diseases. So I just wanted to add that point.
Thank you, Dr. Kennedy. Ms. Morris, you have something to say on that?
Yeah, I agree with both Dr. Kennedy and Dr. Sarpong about this. I think just going a little deeper, particularly as a layperson, when you hear those kinds of comments, and this is my concern with it, right, is that, again, with the statistics about the disparate impact of this disease and what's happening, Richmond, Virginia, one place that you didn't name, David, last week they reported that all of their deaths had been African American. And which is a startling statistic again. And so when you hear those stats combined with this kind of language, it leads certain people to believe that this is a Black people problem. And that doesn't bode well for us. And so while the language, again, to urge people to be safe and to speak to them in language that is accessible is one thing, but you also have to think about the consequences of those decisions. And you also have to look at these calls to reopen, these calls to reopen our economy, and wonder how many of these folks would be making these calls if they truly thought that the folks that looked like them and their family members were at risk. The narrative that was being advanced that the elderly and the seniors needed to sacrifice themselves for the future, that didn't stick. This is sticking, right? This new narrative, when it's laid out in black and white, pun intended, who's dying, that makes those kinds of conversations easier to have, and we have to talk about that. We have to be able to say, if folks really thought that they were risking their own lives, really thought that they were risking the lives of their family members, would they be this eager to reopen, and especially when you look at the industries that we're talking about, who are the workforce, who will get laid off if these businesses are reopened, and then who will die? We're seeing those stats. So again, as a non-healthcare professional, that is what I think about when I hear that kind of language, especially coming from someone like the Surgeon General.
And if I could make one quick comment, I have a couple comments through the themes of what's been said. You'd asked about health literacy and how we got here. Is there a health literacy problem? Of course. We don't communicate as a healthcare profession as well as we should to all communities in a directed way that we should. And there needs to be greater efforts for that, and there's been work around that for ages, but nothing that's come to fruition. What I think that's also important, which was praised earlier as well, was the aspect of having a targeted approach to understanding the data better. Because, again, if we're just going to separate black and white and not do all the races, or if we're just going to do one age group and not the other, like, we have to stop simplifying and deal with the complexity of the issue in the way it needs to be sort of stratified so that we can understand from a targeted approach who is dying and why, at what level, so that we can have the appropriate intervention. The other component I can tell you is just 2 months ago, this disease is very contagious and very dangerous. I can tell you 2 months ago, as a physician on the floor at a particular hospital that would be left unnamed, we could not order a test unless a patient came in from China, despite their viral panel being negative and the person qualifying for a COVID test. So that means myself, as a physician, would then not have to wear PPE or anything based on the designation 2 months ago. Knowing better than that, my colleagues and I united to sort of say, hey, there's something wrong with that. Now, that's me as a physician, but that doesn't mean that the personal care assistant or the person who is delivering the food, who are disproportionately African-American or Latino, going in there providing the food, that then puts them at risk. And this goes back to what was said earlier. For those people who have less resources, they are also then leaving their home because they have to go do their job. They have to take a transit system sometimes, which exposes them more to the virus. They are then at work without the necessary resources, and they were putting them more at risk. Now, I can tell you one of the things that we're looking at one of the hospitals I'm at, just to go from what the problem is that we've all sort of spoken about, to potential solutions, is also capturing things in a very equitable lens for all sort of races, ethnicities, and genders. And so what we're looking at are things that also take into account implicit bias. So are we having palliative care discussions with people of similar backgrounds the same way? Are we intubating certain people for a shorter or longer amount of time? These are real questions that we need to know. The other component is that data is separated. Representative West has asked about sort of what folks can do from a policy level. Well, I can tell you at the state level, SNAP, WIC, housing, education, healthcare information, those are all different databases that aren't talking to each other to solve a problem about the population. So the more that those are connected to look at a population holistically, the more we can understand it. And I think those are ways when you approach it, not just from a public health standpoint, but also from a hospital standpoint and beyond, to where you can start answering those questions. And last but not least, it's not just COVID-19 that we're looking at here. People now have a fear of going to the hospital for COVID-19, and people also have economic issues, so they're not paying for their medications. They're not going to the emergency room for strokes and heart attacks and everything else. And this will disproportionately affect folks of underrepresented minorities who don't have those resources, who historically the system has been against. So I want to make sure that we don't just highlight this from a COVID-19 standpoint, but also for the other diseases that are not being addressed. And I think the better we collect that data on comorbidities, age, to make the dialogue a little broader, will help target what we need to do to impact, not just from a New Orleans level, but as a Louisiana level as a whole as well, and as a national level. Because there are also, just to mention one last tidbit, on my Latino side, there are Hondurans who are Black who say, well, am I Black or am I Honduran? Do I have to choose? No, I'm both. Or folks are telling me, I'm Haitian and I'm Black. Am I supposed to be one or the other? No, they're both. So we have to collect that data in a way so that then we can communicate in Creole or in Spanish in order to properly serve the population we need to serve and the community as a whole.
Yeah, I just wanted to add to the data issue, because I think it's very, very important. And I think giving only one or some aspect of the data doesn't paint a full picture. And I know, like, if you go on the Louisiana Department of Health COVID-19 site, they do give you the breakdown. They show but they only report in it for the deaths, where they do the breakdown by race, by age, and then the comorbid conditions. And what is really driving it is the top 5 are all cardiovascular related. Hypertension taking the lead with 56, followed by diabetes with about 35%. And then people who initially we thought were more vulnerable actually have low fatality rate, death rate, like people with asthma or pulmonary conditions. Now, the data is not available for New Orleans, but the point I'm trying to drive here is that this virus is not profiling. It will attack whoever comes in its way. So exposure, the initial prevention of exposure is important. But what I was able to do with Mississippi data, because on their Department of Health website, they also break the cases by age and race, and then by comorbid conditions. And if you do the math with that, African Americans in Mississippi are disproportionately represented among cases. and this disproportionately represent when you look at those who are dying. But what I did was I calculated the fatality rate between the two races. And African Americans were 4.4%. So for every 10, for every 100, for African Americans, closely for, well, let me make it easier. For every 1,000, maybe about 44 African Americans would die. For every 1,000 whites, 43 of them would dying. So the fatality rate within race is the same. But because we're disproportionately more cases and we have all these comorbid conditions, when you do the math, we come representing more in terms of mortality. So I think we also need to really look at the data, make sure that the messaging we're sending is really appropriate. I'm not saying the picture looks the same in Louisiana, but we would need some more data, and that would be something that we advocate for in terms of having more comprehensive, integrated data so that we're not too quick to make statements that may not actually pan out, but that we would do a critical look, that our decisions would be data-driven and really addressing a long-lasting issue, which is these injustices and social inequalities. I think underneath all of that, that's what's playing out. And it's reflected in terms of the numbers of people of color dying. So I think we really need to take a very good comprehensive look at this issue.
And the one last thing, I just wanted, I was going to add one more thing. There's still so much we don't know. And we have to be honest and open about that, about this disease. And so I know when we don't know something, it leads to fear, but we have to be open and honest about it in order to properly address it.
And I'd just like to add briefly, I pretty much, I think all of the comments that were made were spot on. I want to go back to Dr. Sarpong's comment about us and the tendency of us to sort of rush to some level of judgment or conclusion. But we simply have to acknowledge the fact that much of this is not simple. It is very nuanced and challenging. And your initial point around the blame and is there anyone to blame? Anytime there's a crisis, we want to be able to blame someone. So I think we already live in a society where we're looking to oversimplify very complicated issues. And this is one that is just compounded of a number of different issues that simply cannot be simplified because there's just so many underlying issues at play. But to the point around health literacy, I just want to speak from a personal standpoint. And I'll mention my parents, for example. My father would check every box, you hear me, with a bold check of comorbidities, of these underlying issues. And I think about his experiences over the past 10 to 20 years and all of the health challenges that he has overcome. Had it not been, in my opinion, had it not been for my mother, who was really there all along and would literally show up to the doctor's office with a notepad and did so much research and challenged the doctor to the point where when I'd be on visit, I'd be uncomfortable because, just the level of questioning and challenging. And I think, wow, and it could be that one question where they're able to discover an issue that could solve something that wasn't detected, right? And that can create some issues at times because of that disconnect. And Dr. Kennedy talked about the importance of cultural competency when communities from one part of town are having conversations with, could be a cardiologist or this specialist, that they can have open and honest dialogue without there being fear of judgment or criticism. And people feel empowered to ask certain questions about their health status, right? So I just know from personal experience how important that is, because I think, wow, had my mom not been a stickler for the details, right? And had she not been as empowered as she was in a certain instance to ask a certain question, what would have been the outcome? And I think we see a lot of that, too much of that in our community.
Couldn't agree more, Royce, and with all of your comments. And it brings So I'm listening to Dr. Sarpong, and what I think I heard you say was that there's no significant difference in regard to race and morbidity rates in Mississippi. That really it all comes down to underlying conditions and those social determinants.
Right. What I meant to say is what I was saying was that if you look at the fatality rate, that means that for people who get infected, what percentage of them actually die? It's 4.4% for African Americans and it's 4.3% for whites. So it's looking at how fatal the virus is. The fatality rate is not significantly different, but because more of us are infected and we have these underlying comorbid conditions which are structural in nature, so it gets into some of the social structure issues. We are being affected more, and therefore we're overrepresented in the death among the percentage of death. Because basically the way they're coming up with the 56% for Louisiana is you look at all the number of people who died, you take how many blacks who died divided by the total deaths, and we're 56%. But when you actually look at the fatality rate, because we're overrepresented, we have large numbers of us who have been infected. If you take those who died, who are African Americans, divided by the total number of African Americans affected, the percentage is 4.4%. So for every 1,000 cases, 44 of them are dying. And then for whites, for every 1,000 that are infected, 43% of them are dying. So the fatality rates are not different. Gotcha. But it gets back to some of these structural issues. So the whole point I'm saying is that we don't want to get the message out as if the virus itself is discriminating, because people might go on a tangent and say, oh, well, the virus affects more Black people. No, there are other situations that are causing us to be more affected, and therefore, and the damage is doing biologically is the same whether you're Black or white. So again, we're saying that we need to begin to do certain things on our own, one, to prevent getting the virus, and two, to ensure that if we do, that we're part of that recovery group. But the other thing also I want us to take a look at all of this is that I think if we're going to deal with some of these social injustice, we need to move from a disease model to a wellness model as a nation and as a state. What do I mean by that? The whole point we made earlier is that if your immune system is strong, you most likely would beat the condition. Louisiana right now, for every 100 who got the virus, about closely 64 of them are recovering, but nobody's talking about the recovery numbers. And how do those people look? Who is recovering? So we also need the statistics on who's recovering. And maybe we can learn from who's recovering and begin to work in our communities to help promote people getting for people to get them to recovery. But we're only focusing on the folks who are dying. I think, again, we need a balance, and not approach it only from a disease model, but also from a wellness model. Otherwise, we're going to be having the same conversation 30 years from now with another pandemic or another outbreak.
We definitely don't.
Dr. Sarpong, the only one thing I'd say is that also looking at recovery and death, we have to look at the beginning and go back to access to the tests and access to care, and make sure that's also done in an equitable manner so that we approach it holistically as well.
It's a great.
I would like to add that I bring those three comments together for me. One of the challenges is that, like Roy said, this is complicated. But what ends up happening is that we are often offered the wrong solutions to complicated problems. That is, what I heard Dr. Sarpong say and Dr. Gershang say is that, Esteban, is that we need to be getting the right solutions to these complicated problems. What happens is our leaders, the policymakers, the folks who we trust, to make these decisions do not have the will to go far enough, to do the things that end these inequities. And so we get these half measures, or really the wrong solutions to these very complicated problems. And then when they don't work, there's just kind of a shrug like, well, we tried, right? We tried. It's complicated. And really, there has got to be some critical examination of these opportunities. I keep seeing in the chats, what are the solutions? What are the solutions? What are the solutions, right? Because people want to understand what we can do, because they do not feel empowered. They do not feel like this system will actually respond to their needs, because everything tells them that assumption is correct, right? The system is not geared to the benefit of the many. It is geared to the benefit of the few. And again, we have to keep having conversations like this and lifting up those solutions so that our community understands them and they can participate. And that's got to be a big part of it. Transparent participation, sharing information. It's complicated. Take the time to educate people. Take the time to explain it to people. Do not speak in, jargon and, complicated language, and community doesn't understand it. Break it down. Take the time to break it down, and we see this disaster after disaster. The CARES Act funding right now that's come down from the federal government has a 5-day comment period. 5 days. And there's been no guidance on how the 5 days even goes. So you have folks who are responsible for collecting this input who are not even sure how they're supposed to how to deploy this. What is the rationale behind that kind of vagueness? It's deliberate, right? It's the more questions, the more confused our leaders are. Guess what? They can't communicate clearly to us. And everybody's got to stop and recognize their part inside of this broken system and demand that it be changed. There are some simple solutions, some straightforward things that can get us started. And again, looking at the pots of money, the resources that are still available, and being thoughtful and saying, will this lead to more people becoming sick, or will this lead to being more people made safe? These are some real simple metrics that all of our decisions need to be evaluated against, not whether or not person A or person B or multimillionaire A or multimillionaire B business can open.
Amen. I'm going to, since we got on solutions, I'd like to talk about testing. Dr. Kennedy mentioned testing and antibody testing. And one of the earlier questions that we got in the Q&A was around these tests. And the attendee said this is bringing back memories of the Tuskegee experiment. Now that seems a little drastic, but I do think there's a paranoia around these sorts of things within Black and Brown communities. Can you talk to us, all of you, but especially Dr. Kennedy, about the antibody testing? Is it safe? Are the vaccinations? I don't know what treatments are on the horizon that you can conjure up in your in your wonderful head.
Well, testing has been a problem. I was going to chime in before when we were talking about going back to the beginning. I think the policy that we got from the beginning, which said, oh, if you feel sick, you call your primary care physician, and then you get, permission to be tested. Well, how many people in our communities have these primary care physicians that they can call on the phone and say, get a test? So that, I think that has been a problem, and that may be one of the reasons that we have so many deaths, because people were late getting to get health care. I also think that now that they're opening up the test, and I think the governor mentioned this yesterday after Dr. Burks said that more people should be tested. If they loosen the restrictions on who can be tested, then everyone has an opportunity to be tested, so they'll know whether they are positive or not. So I think that will help us all to know, who's been exposed. One of the messages from the governor is that he would like for the task force to try to remove the stigma from testing. And I think that may be, especially in our communities, that may be a problem. Some people may feel if I get tested and I'm positive, what does that mean for me? Will people look at me differently? And we really just need to know if people are positive. That helps when you talk about contact tracing to decrease the spread of the disease. So that's something that should have happened. And I think we have seen in the New Orleans area and the surrounding areas, more testing in areas like at Xavier, places where people may not have a car to drive, but they can walk up and they can be tested. So that's happening. The antibody testing is another area that will ramp up. I'm not sure where we are with that yet in the state. Some of that is happening, but that's something that will continue to grow, and that will help us to identify who has been exposed to the COVID-19. Now, we don't really know yet what that really means. You know, we don't know what the level of antibody response should be, if that is going to mean that you will not get it again. Those are things that we still don't know and we have to learn. But it is a resource that we have that can be used to help us to identify places where people have been exposed, to help us with tracing and to decrease the spread of the disease.
Thank you, Dr. Kennedy. That was one of the key questions I think that keeps coming across and came across in the original link to register, was about antibody testing. I am mindful of time, and we have almost run out of it. And so what I'd like to do is to have each of you offer your closing comments, to touch on anything that you have not covered or that we did not cover today, and to do that within 7 minutes. That's the challenge. Who wants to start?
I'll start.
Thank you.
So to go back to Dr. Kennedy's statement about antibody testing, I was on a phone call with a local hospital system just earlier today about planning their rollout of antibody testing, and then, you know, hopefully offering it to the community in a larger capacity. Also, you know, some of the comments that Dr. Kennedy stated and you about, you know, fear and frustration about doing the test, you know, I brought that up. And I say that to say that when we're planning these research studies, organizations, policies, we need to have diverse participants at the table so that, you know, we're included in the decision-making process, we're included in how we plan out our strategies so that the needs of our communities can be lifted up. But we also need people in the community to organize and make their voice heard by whatever means they need to do that. The other thing is, I think what's important, because we're in, you know, I'm a public health practitioner, and we kind of think in a health and all policies framework that every policy that's developed has an impact on a person's health or a population's health or a community's health. And so we need leaders who are able to talk about the historical impacts of some of the policies that have been created, and who is willing to step up and talk about race-related issues and learn to pioneer some of those conversations within their own organizations, so that we are better at reaching our communities and treating each other well within our own organizations.
Thank you, Dr. Harris.
Well, I'll go next. First, I want to say that your voice, everyone's life counts, and we need to preserve every life. We all have a role and responsibility to put a lid on COVID-19. So each and every one in our own small way should do the best we can to come together as a community and find and to put a lid on this problem. And then we should all realize that there will be no time and room for us to go to sleep after COVID-19 a lid has been put on it. The work actually begins, and we have to bring data, we have to bring our intellect, and we all have to come with a common vision and mind to try and solve this injustice, inequalities that exist in our community, such that things like COVID-19 always just puts it in the spotlight.
Thank you, Dr. Sarpong.
I'll just say briefly again, thank you for leading this discussion. Thank Xavier and the Center of Equity, Justice, and Human Spirit. I think those three themes are important because to achieve equity and to achieve justice, you can't do it without the human spirit. And I think that this may be philosophical, but I think it's very key. And we have to put a priority on empathy in our conversations around policy. I think that is at the core. From a practical standpoint, look, the federal government just cut a $2 trillion check without blinking in 2 days. So you can't tell me that these problems can't be addressed because we just, as a federal government, wrote a $2 trillion check without blinking. So it's just all about political will, courage, and commitment to righting the wrongs of the past. And until we do that, I mean, we're going to remain in these circumstances that we're in. But I appreciate the opportunity to be a part of these conversations, and I lend myself to remain a part of that effort. So thank y'all so much.
Thank you.
I just want to add to those comments that have been made. I think, again, we need to look at this problem holistically. And we just heard about the stimulus package that we received, or some people received. But when you think about each policy in an equitable manner, rather than the way that we seem to think about things, did everyone need to get the same amount of money? Did those people who are most vulnerable need to get more? So it wasn't decided that, you know, some people get more, everyone was getting the same. We'll never reach equity if everyone is getting the same.
I agree.
So
I
think that is an important point to take away from this when you talk about, you know, this problem in a holistic way. You can't give everybody the same and think that those who are less, the vulnerable population will get to the point that everyone else is.
I agree wholeheartedly.
Dr. Kennedy, yeah, and I think as many of us probably have learned, some folks have an easier time at the table getting some of these loans and programs that were distributed. So it includes having that diversity, equity, inclusion, not just from testing, but also for all the loans that may go out, for the treatment that they get. And the other thing I'll say is for some of these clinical trials, we have to ensure that everyone is properly represented throughout the spectrum to ensure that we approach this holistically, as you said, in an equitable, inclusive, and diverse manner.
Thank you.
Yeah, that's right. And yeah, and I agree with all of that. I mean, that's part of the issue is what we keep doing is what we did before. These broken systems didn't work, and we keep pretending like just tweaks to the system, even pushing massive amounts of cash through broken systems result in more inequities. That's what we're dealing with. And we have to condemn that. We have to move past them and acknowledge the world that we live in, the needs of the people today. Right now, every vacant unit, every unused hotel room, underused resource, untapped funding stream is a failure. That's it. This is try not do. That's it. We have to stop accepting, again, we can cut a $2 trillion check, and we can't take the time to make sure that it goes where it needs to go. We can't make sure that it meets the actual need. That's ridiculous. And we have to stop accepting the ridiculous. We have to stop accepting these half measures as good enough. People are dying. And this is, again, it's nothing new. It's just been incredibly compressed. And this is the chance, we have to pull ourselves out of this. That's, you want to pull ourselves up by our bootstraps, that's it. We have got to make sure our leaders recognize that we can't keep failing on purpose.
Thank you. There are so many questions left unanswered, so many issues left unspoken about. But I want to thank each of you for offering yourselves and your opinions and your expertise on this opinion and on this virtual panel discussion. Again, thank you from Xavier and from the Center for Equity, Justice, and the Human Spirit. For those of you who are still tuned in, please stay on the line. It's not really a line, but you know what I mean, for a feedback evaluation. And please stay tuned for other webinars that will be sector-based and deeply solution-focused. This gave us an overview of the things and the issues that we need to confront, right? So that this never happens again, and so that we can make more equitable our healthcare systems and healthcare access. Again, I thank each of you and thank you all for tuning in tonight. Thank you.
Thank you.
Be well.